So this is the activity for Chapter 20, the heart. And we're going to start with Part 1, Roger's heart attack. Roger Crockett, a 68-year-old man with a 40-pack-a-year smoking history and recent complaints of angina upon exercising, collapsed while mowing his lawn. Paramedics arriving at the scene found him unconscious, not breathing, and without a pulse. CPR was successfully performed and Roger was transported to the hospital. An ECG was suggestive of an anterior wall myocardial infarction, and he was given an intravenous solution of tissue plasminogen activator, or TPA, which helps to dissolve blood clots. Elevated blood creatine phosphokinase, or CPK levels, measured over the next 2 days confirmed the diagnosis. Coronary angiography was performed a week later, revealing the anterior interventricular artery to be 95% blocked. So Part 1 questions. Number 1. What is actually being recorded on an electrocardiogram? Describe the path of the signal conduction through the heart and the events that accompany the movement of the signal. What do the P wave, QRS complex, and T wave represent on the ECG? So an electrocardiogram measures the electrical events of the heart that are occurring during signal conduction through the heart. So if we look at the signal conduction pathway, it starts with the SA node, or sinoatrial node. This is the site where the initial action potential is usually generated. The signal then passes through the internodal pathways, and this will be the stimulus or signal for the atria to contract, which would be atrial systole. The signal then arrives at the AV node, or atrioventricular node. The signal slows at this point so that the atria can finish their contraction. The signal then passes into the AV bundle, which is also called the bundle of His. The signal then passes into the interventricular septum through the left and right bundle branches, and then out into the Purkinje fibers, which are embedded in the myocardium of the ventricles. And when the signal gets to the Purkinje fibers, this is the signal for the ventricles to contract, which would be ventricular systole. So if we look at a graph of a heartbeat on an ECG, the P wave represents the depolarization of the atria, or atrial contraction. So this would be while the signal is going through the internodal pathways. The QRS complex would represent the depolarization of the ventricles, or ventricle contraction, and this would be while the signal is going through the Purkinje fibers. And then the T wave represents the repolarization of the ventricles, which would be occurring during ventricular relaxation or ventricular diastole. Number 2, what is a myocardial infarction? Discuss things that can cause MIs to occur and possible outcomes of an MI. Why was Roger given a substance that dissolves clots? So a myocardial infarction is the technical term for a heart attack. Myocardial infarctions occur when blood flow to a portion of the heart, specifically the myocardium or heart muscle, is cut off. A myocardial infarction is usually caused by a blood clot called a thrombus, which detaches from an atherosclerotic plaque in the coronary artery wall and lodges itself in a coronary artery. The blockage caused by the clot will first immediately lead to ischemia, which is reversible cell damage due to a reduction in blood flow or hypoxia. But then it will rapidly lead to infarction, which is irreversible cell death when blood flow is not restored in time. A clot dissolver like TPA can dissolve the clot and return blood flow to the blocked area of the myocardium, hopefully saving some cardiac cells from dying. But once the cardiac cells have died, the loss of those cells is permanent, and there will be a permanently damaged region of the heart wall. And did you know Myocardial infarctions due to underlying coronary artery disease are the leading cause of death in the United States. Number 3, how could a myocardial infarction cause an irregularity on the ECG? Cell death in the heart muscle can disrupt the passage of the electrical signal through the conduction pathway. A disrupted signal would manifest itself on the electrocardiogram, which is measuring that electrical signal. Possible disruptions include changes in the length of depolarization or repolarization, so changing in the shape and duration of the waves, the P wave, QRS complex, or T wave. You can also get changes in the length of time between one event and the next event, so changes in segments and intervals. And of course, this class is not going into depth as how to read a ECG, but I just wanted to show you some examples. Frequently with myocardial infarctions, you can see what is called an ST elevation, but there are other types of abnormal ECGs that can occur following myocardial infarctions, and so actually being able to read these is beyond the scope of this class, but I just wanted to show you some examples. Number 4, review the blood flow through the heart. Make sure to differentiate between the systemic circuit and the pulmonary circuit. So because it is one big giant circle that the blood travels in, we just have to pick a spot to start, and usually by tradition we pick the right atrium. And then color coding in this chart, blue is going to represent areas with deoxygenated blood, and red is going to represent areas with oxygenated blood. So we're in the right atrium. Blood will pass through the tricuspid valve, which is the atrioventricular valve on the right side, and then move into the right ventricle. Leaving the right ventricle, blood will pass through the pulmonary semilunar valve and then into the pulmonary trunk. The pulmonary trunk will then split into right and left pulmonary arteries. The pulmonary arteries are going to deliver blood to the lungs, where the blood becomes oxygenated. So we are picking up oxygen from the lungs at this point. The blood will return to the heart through the right and left pulmonary veins, and the right and left pulmonary veins will drain that blood into the left atrium of the heart. From the left atrium, blood will pass through the bicuspid or mitral valve, which is the atrioventricular valve on the left side. Blood will then move into the left ventricle. Leaving the left ventricle, it will pass through the aortic semilunar valve, and then it will pass out into the aorta. From the aorta, it will branch out through smaller and smaller arteries, arterioles, until it finally reaches the capillaries of the body. At the capillaries, the oxygen is going to be removed and used by the cells of the body. So now at this point, we are back to deoxygenated blood. And then the blood will leave the capillaries, get picked up by venules and then veins, and then eventually drained into the superior and inferior vena cava, where the blood will return to the heart by dumping into the right atrium. So that is the blood flow, and then it's going to just continue going around in a circle over and over and over again. So the systemic circuit is the part where the blood is traveling through the left side of the heart and going out to the body. So the systemic circuit starts with the left atrium and ends with the superior and inferior vena cava. The pulmonary circuit is the part that is going to the lungs and involves the right side of the heart. So it's going to start at the right atrium and end with the right and left pulmonary veins. Number 5, describe how the heart muscle itself, the myocardium, is supplied with blood. So this is called coronary circulation. So the left and right coronary arteries branch off from the base of the aorta, as you can see on the left side here. The elastic rebound of the aorta during ventricular diastole helps push the blood into the coronary arteries. So blood gets pumped out of the left ventricle through the aortic semilunar valve shown here. And then the backflow of the blood, due to the recoil of the elasticness of the aorta, closes the valves and then forces the blood out through the 2 coronary arteries to the heart muscle. So the left and right coronary arteries each branch to make a total of 4 main coronary arteries. These arteries continue to branch into smaller and smaller arterioles, supplying oxygenated blood to the myocardium. After passing through the capillaries in the myocardium, deoxygenated blood will be picked up by the cardiac veins. The cardiac veins are going to drain into the coronary sinus on the posterior side of the heart, and the coronary sinus is going to drain that blood into the right atrium along with the deoxygenated blood from the rest of the body. So if we look back at our blood flow that we just looked at in the previous question, with the coronary circulation, we're going to start at the aorta. Blood is going to leave the aorta through the left and right coronary arteries. It will then go to the heart muscle, and at the capillaries, the heart muscle cells are going to take oxygen from the blood, and we will now be left with deoxygenated blood. This will be drained out through the cardiac veins, which will dump the blood into the coronary sinus, which will then be returned back to the right atrium, and now the blood is back into the main circuit. Number 6. Think about the differences and similarities between cardiac muscle cells and skeletal muscle cells. Another similarity that was not discussed in the lecture is that both cardiac muscle cells and skeletal muscle cells use creatine phosphate as a means to store excess energy. Think back to what you learned in A&P 1. Creatine phosphokinase, CPK, is the enzyme that transfers the phosphate group back and forth between ATP and creatine phosphate. Why do you think an elevated blood CPK level would indicate that a myocardial infarction has occurred? So first, let's fill out this chart that I gave you comparing cardiac muscle to skeletal muscle. So first, if we look at the number of nuclei, cardiac muscle typically has one nucleus per cell, whereas skeletal muscle fibers can have multiple, even up to hundreds of nuclei per cell. If we look at mitochondria, whereas the skeletal muscle does have a lot of mitochondria, it is much less abundant when compared to cardiac muscle, so cardiac muscle cells have far more mitochondria than skeletal muscle cells. The same is true of the blood supply. Even though skeletal muscle does have a good blood supply, it is sparse if you compare it to the cardiac muscle, which has a very extensive blood supply, and this is that coronary circulation that we were just talking about. As far as reserves go, cardiac muscle has abundant reserves of myoglobin, which helps to store oxygen. Skeletal muscle, on the other hand, has very little myoglobin. Cardiac muscle also has a store of lipids that the mitochondria can use to make ATP. Skeletal muscle has few lipids. Cardiac muscle does have a store of glycogen, but in this case, skeletal muscle wins. It has the most extensive glycogen reserves. And glycogen is the stored form of glucose, and glucose is used by the mitochondria to make ATP. The stimulus for contraction. Cardiac muscle doesn't need a stimulus. It has autorhythmic pacemaker cells. That doesn't mean that the nervous system and endocrine system can't adjust the rate of the pacemaker cells, but it is able to beat on its own. Skeletal muscle requires a stimulus from a somatic motor neuron before it will contract. Intercellular connections. Cardiac muscle has those intercalated discs, which are made up of gap junctions and desmosomes. They also have connective tissue fibers. Skeletal muscles do not have intercalated discs. They only have connective tissue fibers. The resting state, cardiac muscle never rests, so your heart can never take a vacation. Skeletal muscle uses aerobic respiration during its resting state. And then in the active state, which for cardiac muscle is all the time, it uses aerobic respiration, whereas skeletal muscle has the option to switch to anaerobic respiration when oxygen levels are low. And then cardiac muscle has a very long refractory period, which means it cannot undergo tetanic contractions, so it can never reach tetany, whereas skeletal muscle has a short refractory period and there is the possibility for tetanic contractions. Now, for the second part of the question about the CPK, as a reminder from last semester, this was covered in Chapter 10. In muscle cells, excess ATP can be converted into creatine phosphate. So ATP, which is adenosine triphosphate, so here's our adenosine with 3 phosphates, can be combined with the molecule called creatine, and the enzyme CPK, creatine phosphokinase, can take one of the phosphates from ATP and move it to the creatine. So that leaves us with ADP, adenosine diphosphate, and creatine phosphate. So the energy is being stored in the CP molecule by transferring the phosphate group from the ATP to the creatine. And then later on, when the ATP is needed, like during a heavy demand on the muscle, the CP can be converted back to ATP. So the creatine phosphate can have that phosphate be transferred back to ADP to remake ATP as needed, and then you have the creatine left over to be used again in the future. And again, the enzyme that catalyzes this reaction is CPK. So the last question, why do you think elevated blood CPK levels indicate that an MI has occurred? Well, creatine phosphokinase is normally found inside muscle cells, so elevated levels of cardiac CPK in the blood would be an indication of cardiac cell death. So as the cells die, their membranes break down and the CPK would be released into the extracellular fluids. So this is an indication that a myocardial infarction has occurred, which has resulted in cardiac cell death. That is usually the only time you will see cardiac CPK in the blood. Number 7. Rogers' blocked artery, the anterior interventricular artery, resulted in irreversible damage, cardiac cell death, in his left ventricular wall. Following his MI, doctors heard a heart murmur when listening to Rogers' heart. A review of his medical history shows no prior history of a heart murmur. How could the myocardial infarction have resulted in a heart murmur? Hint, think about all of the muscles in the wall of the left ventricle. So the wall of the left ventricle not only has the myocardium that has the cardiac contractile cells, but it also has papillary muscles, and the papillary muscles in the wall of the left ventricle could have also been damaged due to the MI and resulting cell death. So as a reminder, papillary muscles normally contract just before ventricular systole to pull on the chordae tendineae that are attached to the atrioventricular valves, which would be the mitral valve on the left side, and they contract to pull the chordae tendineae taut to prevent the AV valve from prolapsing, meaning going too far back up into the left atrium. So if the papillary muscle in Rogers' left ventricle wall was damaged, then the bicuspid mitral valve might be extending too far back up into the left atrium, and that would be called a mitral prolapse. And a mitral prolapse would result in regurgitation, which is backflow of some of the blood from the left ventricle back into the left atrium, and this results in a heart murmur that could be picked up with a stethoscope. And here is another image to show you a mitral valve prolapse and the resulting regurgitation of blood from the left ventricle back into the left atrium, which sounds like a heart murmur. Number 8. How might the damage to Rogers' left ventricle wall affect his circulation? Think about consequences to both of the circuits, systemic circuit and pulmonary circuit. So I'm going to put the whole blood flow that we talked about earlier up on the screen so that we can look at what will happen. So remember, Rogers' problem is now that he has cardiac cell death in his left ventricle wall. So the left ventricle is not able to pump like it would normally do. All right, so there's my X. It can still move some blood or else he would be dead, but it's not able to move a sufficient amount of blood. So what is that going to do to the overall blood flow? Well, that's going to back the blood up, right? So it's going to be backed up here, backed up here, backed up here. Boom, here's our first problem. All right, so the blood is going to be backed up into the lungs. So the reduced ability of the left ventricle to pump blood into the systemic circuit is going to cause a backup of blood in the pulmonary circuit, and in particular the lungs. So the end result, not enough blood in the systemic circuit, so remember that, not enough blood in the systemic circuit, and too much blood in the pulmonary circuit. So number 9, as a consequence of his heart attack, Roger is left with left-sided congestive heart failure. Congestive refers to fluid buildup in the lungs. Look at your answers to question number 8. Why do you think fluid builds up in the lungs? Which term more accurately describes the stress placed upon Roger's heart? Increased preload or increased afterload? Think about just the left side of the heart for the second part of this question. All right, so let's answer the first part first about the fluid buildup in the lungs. Because blood is backing up into the pulmonary circuit, as we just saw on the previous question, fluid begins to accumulate in the lungs. We're going to cover all of the details as to why this happens when we get to chapter 21, but the short version is that the higher blood pressure that results in the pulmonary circuit from having more blood in the pulmonary circuit, the higher blood pressure forces more fluid out of the capillaries and into the lungs tissues. And so that results in this fluid buildup in the lungs. So left-sided heart failure involves a number of symptoms that both represent decreased blood flow in the systemic circuit. So you can have things like cyanosis, where your skin starts to turn blue from a lack of oxygen in your tissues. Also things like restlessness and confusion, tachycardia, and an increased heart rate. All of this is because the systemic circuit is not getting enough blood. And then these other symptoms like shortness of breath, the crackling in the lungs, even coughing up blood-tinged sputum, all of these are due to the increased blood in the pulmonary circuit. So because of the large amount of blood in the pulmonary circuit, Roger has more blood than usual coming back into his left atrium. So he has increased venous return on the left side. See our answer to number 8 to refresh your memory. So because the left ventricle is receiving more blood during each cardiac cycle, it is having to deal with an increased preload. So the second part of the question was asking you if the left ventricle had an increased preload or an increased afterload. And remember, preload is the filling of the ventricles. Afterload is the force needed to open those semilunar valves. So the answer is that the left side of the heart has more blood coming into it from the backup in the pulmonary circuit. So the left side of his heart is dealing with an increased preload. Part 2, Martha's swelling. Martha Wilmington, a 74-year-old woman, presented to her physician with complaints of increasing shortness of breath upon exertion. She also noted that the typical swelling she's had in her ankles for years has started to get worse over the past 2 months, making it especially difficult to get her shoes on toward the end of the day. In the past week, she's had a decreased appetite, some nausea and vomiting, and tenderness in the right upper quadrant of the abdomen. On physical examination, Martha's jugular veins were noticeably distended. We're going to talk about the jugular veins in chapter 21, but these are the really large veins in your neck. And when we say that they are distended, that means they are very obvious. By looking at the neck, you can actually easily see the jugular veins because they have an excess volume of blood in them. Number 1. Examination of Martha revealed stenosis of her pulmonary semilunar valve. What consequence would this have on Martha's circulation? Think about consequences to both of the circuits. So again, I'm going to put our big giant circuit up here so that we can look at it. So the problem here is that she has stenosis, which is hardening or narrowing of a valve. And in this case, it is going to be the pulmonary semilunar valve, so I'm putting an X there. So that means blood is having trouble making it past this valve. So let's see what that will do with the blood flow. So that's going to back blood up into the right ventricle, and then backed up into the right atrium, backed up into the venous system, and then boom, backed up into the body. So here is where our problem is. So the reduced ability of the right ventricle to pump blood into the pulmonary circuit because of this hardened and narrowed valve due to stenosis would then cause a backup of blood into the systemic circuit. So the end result, not enough blood in the pulmonary circuit and too much blood in the systemic circuit. So this is essentially opposite to what Roger's problem was in part 1. Number 2, further examination of Martha reveals an enlarged liver, a moderate degree of ascites, which is fluid in the peritoneal cavity, and significant edema, swelling of the ankles. What is a possible explanation for these findings? Think about your answer to question number 1. So because blood is backing up into the systemic circuit, fluid is accumulating in multiple areas throughout the body. Again, we're going to cover all of the details as to why this happens when we get to chapter 21. But the short version is that the higher blood pressure that results in the systemic circuit from more blood in the systemic circuit forces more fluid out of the capillaries and into the body's tissues. So again, we are going to go into more detail in chapter 21, so this is just a brief introduction, and it's kind of a simplified diagram. But what we're going to see in chapter 21 is that at capillaries, there is a balance between fluid that leaves the blood vessels and goes into the tissues, and then fluid that comes from the tissues and goes back into the blood vessels. And normally those amounts are balanced out, but in the cases of very high increased blood pressure, like with the backed up blood that is in the systemic circuit, you get an imbalance in this fluid exchange. And so more fluid ends up coming out of the blood vessels and into the tissues, which causes edema, which is a swelling of the tissues. And ascites you might not have heard of. This is when this fluid buildup actually happens in the peritoneal cavity. It can even cause the stomach to distend outward because of the fluid buildup in this cavity, and that is what ascites is. Number 3, Martha's condition is termed right-sided congestive heart failure. In this case, congestive refers to the fluid building up in her body. Which term more accurately describes the stress placed upon Martha's heart? Increased preload or increased afterload? And we're thinking just about the right side of the heart this time. So before I answer that part of the question, let me briefly talk about right-sided heart failure. So it's the opposite problem of left-sided heart failure. So with right-sided heart failure, there is not enough blood in the pulmonary circuit and too much blood in the systemic circuit. So you have an increase in blood pressure in the systemic circuit. You can get ascites. You can end up with an enlarged liver and spleen. You can have those distended jugular veins, anorexia, complaints of GI distress, swelling in hands and fingers, and then edema in multiple areas of the body, including the ankles and lower legs. So if we think about this condition in Martha's case, is it affecting preload or afterload? The answer is actually that Martha's right ventricle is actually dealing with both an increased preload and an increased afterload. So again, as a reminder, preload is the blood that is coming into the ventricles during the filling stage. So it is how full the ventricles get at the end of their diastole. And afterload is referring to the force necessary to open those semilunar valves. So the increased preload in her case would be from the increased venous return from the backed up systemic circuit. So she would have extra blood coming into the right ventricle from the backed up blood in the systemic circuit. And the increased afterload in this case is because she has stenosis of her pulmonary semilunar valve, which means that when the right ventricle squeezes, it has more difficulty in opening that pulmonary semilunar valve because of the stenosis, and that would be an increased afterload. Number 4, to help correct her condition, Martha is given a drug that increases the contractility of the heart by increasing calcium ion concentrations. Review the 3 stages of a cardiac action potential and the ion responsible for each stage. How does increasing the contractility affect the cardiac output? Be specific about which component is actually being changed, heart rate, in systolic volume, in diastolic volume, etc. So to answer the first part of the question, I'm going to put up a action potential and a ventricle contractile cell. So the first stage will be the depolarization phase, and during this phase you've got sodium that is entering the cardiac cell very rapidly through voltage-gated fast sodium channels. The second phase will be the plateau phase. This is going to be calcium, which enters rapidly through voltage-gated calcium channels, and this is going to maintain that depolarization, which is why it's called a plateau phase, because it makes the membrane potential plateau or flatten out for a period. And then the repolarization phase is when potassium is leaving the cell through slow potassium channels. All right, so for the second part of the question, how does increasing the contractility affect the cardiac output? Let's first throw up our equation for cardiac output. Cardiac output is heart rate times stroke volume. So increasing contractility is going to mean that the ventricles are contracting or squeezing with more force. A more forceful ventricular contraction is going to force more blood out of the ventricle. This would mean that less blood is going to be left behind, which would be a decreased end-systolic volume, or ESV. So here is my equation for calculating stroke volume. Stroke volume is end diastolic volume minus end systolic volume. So I just said I would have a decreased ESV. So decreasing the ESV is going to mean a larger stroke volume. So if I decrease this second number, I'm subtracting less, which means the stroke volume will increase. And if I increase the stroke volume, this is going to mean an increase in the cardiac output. So if I go back to this equation, increasing this number here is multiplying this number by a higher number, which is going to increase the cardiac output. Part 3, miscellaneous questions. And these are actually some of the questions from the end of the chapter, review questions at the end of the chapter. And that's why the numbering is a little bit weird. I just wanted to discuss these with you. So number 28. Vern is suffering from cardiac arrhythmia and is brought into the emergency room of a hospital. In the emergency room, he begins to exhibit tachycardia and as a result loses consciousness. Explain why Vern loses consciousness. So tachycardia means a faster than normal heart rate. So normal heart rate is usually between 70 and 80 beats per minute, but a normal sinus rhythm could be anywhere from 60 to 100 beats per minute. And then tachycardia with still the normal rhythm would be called sinus tachycardia, and that's technically greater than 100 beats per minute. As the heart rate increases, though, the time spent in diastole decreases, and when you get up to around heart rates of 180 beats per minute or greater, then you are spending way too little time in diastole, and that means that the heart has less filling time for the ventricles to fill with blood between each beat. So it is during diastole that the ventricles are filling up with blood. So as the heart rate gets past a certain point, usually around 180 beats per minute, the cardiac output decreases and less blood is being pumped out to the body. Less blood pumped to the brain results in a loss of consciousness because the brain needs a steady supply of oxygen, which it will not get if not enough blood is being pumped out of the heart. Number 30. The following measurements were made on 2 individuals. The values recorded remain stable for 1 hour. Person 1, heart rate 75 beats per minute, stroke volume 60 milliliters. Person 2, heart rate 90 beats per minute, stroke volume 95 milliliters. Which person has the greatest venous return? Which person has the longer ventricular filling time? So let's first use this equation, cardiac output equals stroke volume times heart rate, to calculate each person's cardiac output. So person 1 has a heart rate of 75 and a stroke volume of 60. So their cardiac output would be 4,500 milliliters per minute. Remember, cardiac output is the amount of blood pumped out in 1 minute. Person 2 has a heart rate of 90 beats per minute and a stroke volume of 95. So person's 2 cardiac output would be 8,550 milliliters per minute. So now let's answer the first question, which person has the greatest venous return? So venous return, which is the blood coming back into the heart, is normally directly proportional to the cardiac output. So if there's nothing wrong with the heart or nothing wrong with the system or the pulmonary circuit, then the volume being ejected from the heart must equal the volume that is returning to the heart. So normally venous return would be the same as the cardiac output. So therefore, since person 2 has the highest cardiac output, they would therefore have the greatest venous return. And then the second question, which person has the longer ventricular filling time? So remember, we just said that ventricular filling time, which takes place during diastole, decreases as the heart rate increases. We just covered that in the previous question. So person 2 has a higher heart rate, so they would have a smaller filling time. So the answer, therefore, is that person 1, who has a lower heart rate, would have the longest ventricular filling time. And then last question, number 31. Karen is taking the medication verapamil, a drug that blocks the calcium channels in cardiac muscle cells. What effect should this medication have on Karen's stroke volume? So remember, blocking calcium will decrease contractility. Calcium is needed to come into the cardiac muscle cells in order to have them release the calcium that is stored in the sarcoplasmic reticulum. Decreasing the contractility would mean that less blood is pumped out with each ventricular contraction, meaning that the end systolic volume, or ESV, would be increased because we are leaving more blood behind after we squeeze. So increasing the ESV will decrease the stroke volume. So more blood being left behind means less blood being pumped out. Therefore, Karen would have a decreased stroke volume. And that is the end of the Chapter 20 activity.